don't want to make anybody feel like I think that their dreams are silly or unrealistic. But I do think that there's a difference between compromise, like just compromising on what you want to do, and then having a little bit of a reality check per se on like what your real life is going to have to look like.
My guest today is a good geezer, as the Brits say, or un berraco, as the Colombianos say, or perhaps a class act, if that's more familiar to you, as opposed to the vagabonds that I regularly have on the show. It's Dr. Neil Chappell. He is 4 years out of his fellowship, which he did at Baylor. And the reason I wanted to have Dr. Chappell on the show is because he's recently bought into his practice, Fertility Answers, with Dr. John Storman, who's been on the show. Dr. Chappell practices out of Baton Rouge, Louisiana. And so he's part of what I might call the sophomore class here. He is neither just out of fellowship. It's not the first year or two of his job. He's grinded his teeth a little bit and gotten familiar with the system and now has bought in. So I've had senior partners on the show, many of them. I've had many CEOs on the show. I've had some fellows on the show. I haven't had too many of this very new partner on to share her or his experience. And I'm glad Dr. Chappell came on because he gives good context to what younger doctors might consider. He lays out 3 goals for a first job. Says there's 3, not more than that. We also talk about geography. We talk about learning the general field of business. We talk about how to integrate new processes, the process for processes. And we talk about some important education that he's found along the way. Like many of you, Dr. Chappell is someone that has continued his education. He went on to do chief residency when he was at University of Alabama after his program there. While he was doing his fellowship training at Baylor, he also received a Master of Science in Clinical Investigation. Now he's learning the business side, and he shares some of those lessons with you. So I hope you enjoyed today's episode with Dr. Neil Chappell. Dr. Chappell, Neil, welcome to Inside Reproductive Health.
Thanks, Griffin. It's great to see you again.
You're a fellow podcast host, so it's good to have you on the show. I will tell you, Neil, that I have, not every week, but a couple times a month, someone reaches out and says, I didn't like what this person said on the podcast, or I didn't like this idea. And recently I had someone call me and said, were you doing a commercial for this group? I said, no. And it sounded like a commercial. And I said, I don't think so, but I'll go back and listen. And I went back and listened. And, the first soundbite I was talking to my podcast manager about, and she said, you were borderline accusatory to that. So some people have views one way or another, but very often they just want me to do their dirty work. And every single episode, I say, if something is said on the show, you have an opportunity to come on and express a different view. And very few people have taken me up on it. One of them has been your partner, Dr. Stormont. Some of them have been Tracy Keene from Mate, Dr. Brower from Shady Grove in New York, and Dr. Arredondo. And those have been pretty much the only people that have said, no, I didn't like this part that someone said, I think a rebuttal is necessary. And so there's been very few. And recently, we've had some content about partnership, about what new docs want. And there was something he said, I think another view needs to be expressed here. So what was that?
Yeah, I remember your podcast early on with John, my current partner here in Louisiana, about what docs that have been out for 10 plus or 15 plus years, what they're looking for in new hires. And that was a very salient podcast for me because I was kind of in just starting his practice. And then, fast forward, you interviewed these 3 fellows, and I have a little bit of a different perspective because I've been out now for about 4.5 years. So I'm young enough to remember what was important as a fellow coming into the field, but I'm a little bit experienced enough, certainly got a long way to go and a lot of a learning curve to climb, but old enough and experienced enough in the real world, so to speak, to have a little bit more salient view on the reality, I guess. And so I was thinking, a lot of the things that they said in that podcast, I remember thinking, and I remember hearing from some friends and mentors, no, that's not really what you want, or yeah, that sounds great on paper, but that's not really how it is, those kind of things. And then I got onto the world and I'm like, oh, this is quite a new education. The cliche of you're going to learn a whole lot in your first month out in the real world is a cliche for a reason. It's very true. And so I think that, and I sent an email to you and something to the effect of, hey, we've interviewed folks that are years away from fellowship, and we've interviewed folks in fellowship, but a few folks that have been just a couple years out to kind of see both sides of the coin and maybe shine a little light on where the middle space actually exists. In this polarized day, there's this view way over here and this view way over here, and the truth is probably somewhere in the middle. That somewhere in the middle voice was, I think, just maybe a viewpoint that was missing from the conversation. So I thought that might be something to do.
You're right that we haven't had so many from the sophomore class, so to speak. You're 4.5 years out of fellowship. You're now a partner with Dr. Storman at Fertility Answers in Louisiana. And so what was it? What were those points that were made in that interview that you remember thinking as a fellow or as an incoming REI that you thought that you now think are off base or
off base is harsh. There's just more to it than that.
Well, what were they?
Yeah. So I think first of all, anybody can have the practice that they want to have. This field is nuanced enough and diverse enough. I mean, it's reproductive endocrinology and infertility, and everybody else in the rest of the world thinks, oh, they're just IVF docs, but that's not true. We do so many things. We're trained in so many things. We have the capacity to have very different lives. And, I just reach out to the other 40 folks that graduated with me, and all of our lives are very different. So I don't want to make anybody feel like I think that their dreams are silly or unrealistic. But I do think that there's a difference between compromise, like just compromising on what you want to do, and then having a little bit of a reality check per se on like what your real life is going to have to look like. And so, for example, I think everybody's big on geography. Everyone says, oh, I need to live in these places or live in this city or live in this thing. Or I want to be by mountains or beach or river or by my favorite sports team or something like that. And my feelings on geography are there's probably only one reason why it's important. Well, two reasons why it may be important. If your spouse can only work in one city, you're hosed. You got to go there unless you've got a very interesting relationship. And two, if you really need to be close to certain family, and I guess that's kind of like a 1B because it's the same difference. You want to be close to your spouse or your family, and they're limited in their geography. Okay, fine. You need to be limited in your geography. But I think our generation might undervalue the importance of microgeography. It's kind of the concept that I think. Because at the end of the day, what are you going to do? You're going to go to your house, you're going to go to where you work, and you're going to go to your kid's school if that's part of your family dynamic. And that's kind of it. That's what most of your days are going to look like. And the days off, you're going to go out to eat at restaurants or you're going to go see a show. But most cities in America have those things. You can build a really nice life in just about any town. Go where the market needs you to go. And then from there, build a little microcosm of your world and then go explore the world when you're on vacation. That to me seems the most realistic way to think about geography. So I think geography is just, it's just overemphasized as an important thing. I don't think that in the day-to-day it is as important to me.
So by microgeography, Neil, are you talking about community, building your own community wherever it is that you end your own routine, your home? Is that what you're referencing by?
Kind of. I mean, people are like, why did you go to South Louisiana to start your practice, to build your career? And my answer to that is because this is where I was needed. This is where there was a large market demand. And I knew that, my life was going to be my house and my job and my immediate family here. And so that was, I don't care that I'm not in a big time city or on the coast or whatever, because I've got a really nice patient, market. And I've also got my little microcosm of a family life here.
Are you also close to the family that you're originally from, or that your spouse's family?
Well, yes. So family was one of the reasons why we were like, okay, it's okay to move here. But that honestly wasn't in my top 5 because I spent the majority of my training away.
Your family is not listening.
No, it's okay. They know.
We weren't in the top 5.
No, they weren't because, it's not hard to travel to family. And I spent the majority of my, adult training, 10 years or plus years or whatever, not close to family. So it's nice to have them nearby, but it wasn't necessarily a deal breaker. If the same position was true in Omaha or Buffalo or whatever, then that would be the case.
Well, I don't want to go too far into this point, but I would disagree that it's not hard to travel to family. I think once you have your family established, once you have your spouse's family and you have other obligations, it's not the same thing as being close to them. And the only reason I'm staying on this point is because I am a huge proponent of people moving to small markets. And I think that small cities are where the quality of life is. There's a difference between a small city and a small town, and there's a difference between a small city and a big city. Mm-hmm. And I think for most people, small cities have the quality of life that you're describing, which is when you're a busy professional in Lafayette, Louisiana, or in Manhattan, or in Los Angeles, or in Buffalo, New York. But do you want to have a 50-minute commute? Do you want to have all of the other considerations that come into play? In most of those big city amenities you can't take advantage of anyway. But I think it's easier to travel to the big city amenities, those things that don't really happen in small, maybe like big shows or specific restaurant scenes or social scenes that might be really important to you, these type of niches. I don't think it's as easy to travel to family, depending on what level you want to have access to them. But when I see REIs moving to markets like Lafayette, like Buffalo, like all of the markets that are not in the top 20, it's almost universally because either they or their spouse are from within 3 hours.
Well, that's what I said. The one reason why geography should be important is spouse and family. So on this, I agree. And I guess to your point, maybe a better term instead of microgeography is that the quality of life you can have in a mid-range city as opposed to the top 20 really it's really underemphasized, I think. And so I think from a geography standpoint, unless you have to be in a city, think about those other mid-range cities because they offer quite a bit. And yeah, I wish that another person would grow up in Louisiana and become a fertility doc. I would love to have another partner here because that seems to be the only way to get them down here. That's true.
And it's true for small markets across the country. I think it's a big access to care issue. And I'll keep talking about it on the show because, one, I want more people to consider it for access to care. Two, I'm biased. I'm from small city and I love it. And if you're a top wage earner in the places that we're from, you're royalty. I mean, life is really good in places like here. And as interest rates go up across the country, that house that is now a third affordable of what it used to be because mortgage rates were around 3% last year and they might be 10% next year. Well, guess what? That's not going to be a problem for you in a small city because if you're willing to live in the intermediate house for 3 or 4 years anyway, you're going to be able to buy the next one. You're going to be able to buy it in cash in those smaller markets, that dream house that would cost you 3 or 4 times as much in one of the larger cities. But so geography was one of
the other thing. I think there's the other double-edged sword is research, and I think that where a median conversation could be had is, I think a lot of folks that have been out for a lot of years, they're so used to the high demand for the workload that research. And not that it's not a priority for them, but they want to hire somebody to be able to produce. They want to bring somebody on to see the 1,000 new patients that are on their 6-month waiting list. We need somebody to see patients. And graduating fellows, we're trained so heavily in research because our fellowships are that much longer. That it's just ingrained in us. That research is critical. So it's rare to hear a fellow say, I want nothing to do with research. I want to join a program that has the capability or the capacity to do good research and to contribute to the literature and to help progress the field. And that may be in strict research and grant writing and papers or in industry, any one of those capacities, because again, there's a lot of ways to do that. But I think that where the truth is between those two is that that's just the way our generation is being trained, and that's the way the field is moving. There's so much in genetics, there's so much in AI, there's so much data out there that we're trained to think about that with this impetus and this emphasis on urgency. And this is our duty, this is our responsibility, this is our privilege to be the stewards of these data to put out good stuff. And so we come out of fellowship, we're like, we want to do research. And then the folks that are trying to hire us are saying, we don't want you to do research. We want you to just kill. We need people to see patients. Let's go. And I think probably the truth is we do as a field have a responsibility to produce good research, but from our standpoint, we need to be thoughtful about it. I think it's not necessarily realistic for you to go into a negotiation saying, I want my Fridays completely off to not see patients so I can just work on my research. That's a difficult thing. It doesn't pay the bills. It doesn't pay your salary. But at the same time, we are responsible for making sure that all of this industry stuff and all these new technology and all this new AI, it's coming to the field. Is it really benefiting patients? That's our job to say. So we have a very real responsibility to that, not to mention the responsibility to the next generation to provide them the research that they need to be able to apply for this very rigorous and competitive fellowship. So for the docs that are looking at hiring somebody that tells them they want to do research, don't roll your eyes. That's an important part of who we are. We have to find a way to build time without compromising the bottom line of the business. And for the graduating fellows, I would say, yes, research in that capacity is important, but you have to understand that you need to be in the clinic. And so what you need to learn now is not how to do good research, but how to delegate good research. I've had fellows tell me, oh, I can't wait to be back in the lab pipetting. I'm like, if you're pipetting, you're making a mistake, because your job is not to pipette anymore. Your job is to let someone else pipette on your behalf so that they can get the accolades that they need to earn. They got to earn their stripes too, so they can advance in their field. And you're now their mentor. So you're making that transition from fellow to attending. You got to see patients. You got to work. Research can be a part of your job, but you got to learn how to delegate that research to the residents and the fellows and the other lab folks, behind you, and let them get their names on papers while you forward the field and see patients. And to me, that's probably where the truth lies.
Have you done something like that in private practice? Because I could see that perhaps being less easy to do in private practice if you're not affiliated with an academic center that has a fellowship. And you might have residents that rotate in. But how have you done that?
I don't even really have residents rotate in. There's a residency here, but they don't really rotate with us much. I teach lectures for them. And then if I have a clinical question about what we're doing and making sure we're doing it well, or if I'm reading a paper that says, hey, this is out and I want to validate those data inside our own practice, then I talk to the residency. I've got a good relationship with them. I find a resident that's interested in doing that research with me. I build out the database. I've got a statistician that I've befriended, and I've got a PhD researcher through LSU system that I've made good friends with. And together we kind of collaborate on ideas. And we publish a paper or two a year. And I'm not shaking the earth with amazing science down here, but I'm validating my data with what we know and making sure that we're providing good quality care down in Baton Rouge, Louisiana. And I'm also helping residents get a few papers and doing good things for our patients in our practice. So, John published an editorial this month, and we published a couple papers earlier this year. So we're doing a little bit, but, I'm still seeing patients Monday to Friday and some weekends, depending on how people ovulate. That's still my primary thing, but I do feel a responsibility to do the research. I just build those meetings, either during that, half an hour in between patients between the morning and the afternoon, or in the afternoons after I'm done seeing patients.
It's not a full day off for doing research every week.
You have a responsibility to your patients, just like you have a responsibility to the field. And I think having a healthy appreciation for the fact that you have to pay the bills, and you are the person who pays the bills. You crank the factory to make the widgets that pay the bills. But at the same time, we're called to a higher calling. Fertility is the reproductive endocrinology and infertility, or just physician in general, by definition, higher calling. You got to give some of yourself to doing those other things too. But if you're thoughtful and mindful about it, and you use the training that we've had, you can build a system that sustains itself. We all know how to do a good retrospective cohort study. Build a database, teach them how to go through one chart, and then cut them loose, and then have monthly check-ins via email where you see how they're doing. It doesn't require a whole lot of work. It just requires some thoughtful work. And I think there's a space to have both. It just takes some effort to build.
I'm dubious that a lot of the places that may have said, "Oh, sure, you can come here and do 1 day a week of research," actually end up allotting for that, because I've been on both sides of these discussions with where I've been with just the younger docs and just letting them sound off on what it is that they want, and I've been with the partners and CEOs with a lot of the biggest practices and groups in North America, and I hear the differences in conversation. And on the younger doc side, it's very often like, yeah, they told me that I'll just be able to, have research, and this is what I'm hoping for, and I want to have this kind of time off. And on the other side, it is very clear, like, there's an expectation for them to produce. There's an expectation for them to do volume, and they're on them if they're not.
But of course, that's what a fellow would think. Of course, that's what a fellow would think. We're given 20 months to sit in a room and think. I mean, that 20 months of our fellowship, or 18 to 20 months of our fellowship, we're supposed to sit in a room in the dark and think. And so that's all we've done for a year and a half. Of course, we're going to come out and want to do that more. That's how we were trained. That's our comfort zone. This is our happy place. We sit and we think, we read, and we pontificate on what could be the next big thing because we want to help patients. And there's nothing that gets us lit up like reading about, ovulation. So of course we think that. But again, coming out into the real world for a few years, not that I'm the sage. I mean, your recent podcast with Eduardo, of course, was flawless. That guy's very, very good. He thinks very, very well-rounded in a good 360-degree space. So I don't know if I have anything to contribute after what he said. He's a hard act to follow. But we think that that's our comfort zone. We need to kind of move to the real world and say, oh, but we also have to pay the bills. And research really doesn't pay the bills. Not in this space like that. So that's just kind of that thing. And then the other thing, I think by nature of fellowship, we all love surgery and we all love oncofertility. And I remember telling somebody that I was coming out of fellowship and I was interested in kind of helping to, build out a good oncofertility program and build out a good reproductive surgery program. And this particular person was like, don't tell anybody that. Like, that's not what people that are hiring you want to hear, because it doesn't really give you much in terms of revenue, and it takes a lot of time. And I thought to myself, that's kind of a jaded thought. Like, why would you say that? These are really important things. And then I got into the real world and I was like, oh yeah, surgery takes a lot of time. It does not pay the bills. It is still a major part of my practice. I still do surgery every week, several days a week, but it's not because I think it brings revenue to the practice, but it does bring some value to the practice. And I think that you have to understand the difference. So like, I'm in a small town, market or whatever, or small city market, not small town. It's a small city market. There's really nobody else that does these surgeries here. So it's incumbent upon me. It's my responsibility to provide that care because the market demands it. So that's really kind of why I'm here doing surgery as well. But it does keep me from being here seeing the IVF patients, right? So if you say, I want to go to a program and tell them I'm going to build out the reproductive surgery program, they're going to say, great, then I don't have to do surgery. I can go see more IVF patients. But don't think that you're coming there saying, that's not the same thing as saying, I'm going to come here and I'm going to do 400 IVF cycles. Those are two very different values to the practice that you're joining. And you have to just understand that what you're saying, I'm going to build out your oncofertility program. Well, what that says to some of the staff is, now we got to be on call 24/7 for whenever you get an oncofert call, then we're going to have to come in and we're going to have to do things and figure stuff out. That's a lot of paperwork. And that's not how we feel as physicians, because it's a blessing to be able to help people in a time of need. But the staff and the framework of how the business runs, that's what they see. And for better or for worse, you just kind of have to know that when you bring oncofert and repro surgery or things like that to the table, it's not the same thing as saying you're going to do 400 cycles.
So we're talking about expectations and the reality of what's on the other side of them, but let's also maybe take a little sidebar to talk about, when is it time to say, no, this is really important as part of my vocation. And I did an episode probably 2 years ago now with Dr. Matt Retzloff about surgery and about how much surgery is still in the purview of the REI and always should be. And in your view, we don't have to go too far down this rabbit hole, but I can picture some people listening and them thinking, but that's what I want to do. And so when is it time to say, no, this is my vocation, this is what I'm going to do, versus it's perhaps not realistic for the REI to do some of this anymore?
Well, again, I don't want anybody to think that I'm jaded by any means. I mean, the people that know me know that I'm the happiest, like eternal optimist, incapable of feeling sad, love my job and feel privileged to do it every day. But I think to answer your question I think it just requires a mutual understanding of what your passions are, what the market in your area demands, and how that affects how the business runs. Those are the three things you have to think about all at once. And that was kind of the point of maybe having this conversation be a part of your series, is that you need to talk about all three at the same time. So I do surgery, and I have helped build out a few different oncofertility programs in a few of the cancer centers here in this area. And we're working on helping bring good legislature to the Louisiana government to help to provide better access to care for folks with oncofertility diagnoses. So we're actively working in all those spaces because this market needs access to care and this market needs good reproductive surgery. So here we are doing it. But we're doing that cognizant of the fact that we are compromising our ability to just straight up drive revenue into IVF cycles, because it's important to us that our practice be that access to care for those people. And I think anybody can do anything that they want. Just understand that if you're joining a big, fertility machine and you tell them, I want to just do surgery, they may or may not be the most thrilled to hear that. And I think that's part of the genuine conversation that needs to be on the table. But you have unique training and you have a unique, skill set in this subspecialty that should be leveraged. And so if that's something that is your passion, you just have to understand that your seat at the table will look different than the person that's doing 700 IVF cycles.
If not the REI, then who would be doing the oncofertility cases?
Oh, no, I mean, well, I don't know that I want to go down that rabbit hole with you. That's a different podcast. It's a different question as far as fixing access to care. I don't know how to fix access to care, and I do think it's our responsibility. I'm very big on doing what your patients in your area need you to do. You do. So I just think that you just need to understand that there is a compromise in how you are reimbursed based on the models in your area. And this is different for an academic setting where they're paid on RVUs, and this is different in mandated states versus not mandated states.
And thinking about it back in the frame of expectations, could it be the case that, okay, if this is your vocation and this area for access to care is extremely important, then perhaps that more traditional academic model of working in a university or a hospital REI division is still relevant. And that role as how it was 15 years ago maybe still is relevant today. Perhaps just don't expect these big signing bonuses, this big type of partnership and maybe salary or bonus opportunities that these new big companies are offering, if that's what you want to do. Is that a fair way of looking at it?
Yeah, generally speaking. But it may be that you find somebody that just hates surgery but knows that they need somebody to come down and do surgery with them, and then they're going to see major value in you. So, I mean, we could go down the hypothetical, there's hypothetical A, B, C all the way down to, 123. There's a scenario out there. There's a job out there. I mean, there's so many jobs out there. You're in the bargaining seat just being a board eligible RE. I'm just saying that I think that it's a reasonable thing to say, hang on, you really need to think about this from both perspectives. If you're going to every interview saying, I only want to do surgery, or I want a day and a half to sit and think about research, those particular values to you can happen, but they have different implications that no one's really talking about.
I know a retiring doc of a private practice that does a lot of surgery, and one of the partners does almost none, really doesn't like doing it. And so that could be an opportunity for someone that likes surgery, because the now senior partner isn't doing it and there's still the need there. So that's a possibility. Okay. So we've talked about geography. We've talked about research. We've talked about surgery and oncofertility. Were there other expectations that you've heard from incoming docs on the show that you also had when you were an incoming doc that you now see perhaps need more context?
No, not really. But I would say that the things that I always tell the fellows that call me, and now that I'm in my 5th year out, less and less fellows calling. I knew more back when I was a little closer, but 5 years out, I know less. But in the times that I've had conversations with graduating fellows, I tell them you got 3 goals in your job number 1. And many folks don't stay in job number 1. I've been really happy in my first job. I don't see myself leaving ever, but that's not common. Half of us leave and within 2 to 3 years, I think, is the statistic. I don't know if it's still true, but that was the case back when I graduated. But I tell them you got 3 goals in your first job: pass your boards, learn the business, and pay off some debt. Those are the 3 things you have to do. And so people take this job hunt so seriously because interviewing for medical school and interviewing for residency and interviewing for fellowship was so serious, and there was so much stress and there was so much heaviness in it. But this is a very different interview process. You're interviewing for a marriage, but these are not dates. This is you coming together with someone on a business to business, just talking business. Do our goals, alignments, values match? Be honest and open with them. Because I interviewed with some practices, and I was so scared of telling them that it wasn't going to work out that I just waited and waited and waited to tell them. Then that hurts them. That makes them more angry with me. And I could have just called them and said, "Hey, this is not going to work out." You don't even need to give them a reason to say this is not going to work out. And they would have been like, "Great, thanks for letting us know. We're going to move on." And that would have been probably the right thing to do. But I was so scared to tell them that it was, it became not great. So yes, taking a job is a marriage, but interviewing for jobs is just business. Just be honest with folks about your values and what you're looking for. And keep in mind that really those first few years out, pass your boards, learn a bit about the reality of business, and pay off some debt, both financial debt and family debt. Take some time to thank your family for supporting you through that decade plus of work, and take them someplace nice for a few days and then get back to work, right? So, but that's kind of what I tell folks.
Let's talk about the learning the business part. So there's 3 goals in your first job. It's pass your boards, learn business, and pay off debt. Let's talk about the learning the business part.
Yep.
What were some of the things that you learned?
So there's kind of 3 aspects of learning business, right? So learn the general field of business. And if you treat it like learning a new language, it's really quite straightforward. What I've learned, the more I've learned about business, the more I realize that it's actually not that terribly complicated. It's kind of just algebra. You just have to learn what they call each of the variables. So a P&L statement looks very intimidating and very confusing, but it's just simple algebra. You just have to learn what P stands for and what L stands for. And if you just sit down with the CPA or the manager, the administrator of the practice, and just take an hour with them early on and say, what is this? What's this line item? How do we calculate? And just have them tell you, then you'll catch on pretty quick. So learning the language of business, read a few books and ask a lot of questions early and often on the admin side. That'll help. Learn your practice. So learn the language of business, learn your practice. How do they do things? How do they treat their OI cycles? How do they treat their IVF cycles? How do the nurses work? How do you communicate with them? How do you write in the EMR system? How do you do checkout with your fellow physicians when someone else is on call? Is there a doc of the day thing, or is it eat what you kill and you do all your retrievals? And most of this stuff you'll know in the interview process, but when you actually show up and you're like, okay, I want to do surgery on this person, how do I post that case? Learning how to go about communicating with nurses so that you integrate into their workflow, that's key. Showing up on day one and saying, this is how I want to do everything can be quite disruptive. So for me, when I came in, I was like, okay, copy paste whatever John does, and I'll start there. And then as we grow and learn and find, new ways to do things, or this is what I learned in fellowship, I go to Storm and say, hey, this is something we've been trying to do. This has been really effective. Let's try and integrate that. We slowly integrate it because you rock the boat with the nurses, and that's a surefire way to get thrown off the boat. So learn how the practice works and then sort of integrate what your training brings to the table, because you do know things that can help that practice be better. Just don't try and change everything on day one. And then learn your area. And in the first, when I say learn business, learning the area means you've got to go knock on doors. You've got to shake hands. You've got to be friends with all of the referral people there. You need to learn. You need to know the oncologists, the OBGYNs, the pediatricians, the general medical market. How does it work there? Is it owned by big entities, or are there a bunch of small locally owned private clinics? And where are all the babies being born? Where are the OBC things? Where is surgery done? What's their taste for fertility? Some areas they want nothing to do with fertility patients. They immediately refer them out. Some places like to do a whole bunch of ovulation induction cycles themselves and then refer them out. Who's your competition? And what are the market needs there? Do they have a bunch of people that do minimally invasive GYN surgery? You're not going to need to do much surgery. You need to probably refer all your surgeries to them, or you're going to make some folks very upset. Or is there nobody there doing surgery, and that's going to need to be a major part of your market? And what are your competitors doing there? And how do you need to think about offering a new option or a new solution because they've already got the market cornered on X, Y, or Z?
We can talk about that, know your area a bit more. It could probably make a whole episode about that, but I think it bears exploring a little bit here, because that's a huge opportunity when you're in your second year of practice, because you've got a little bit more time. And as you become more established, and when you really get busy and you have the partnership responsibilities and you have a long wait list of patients and different obligations, then you often need a physician liaison system. And so the whole infrastructure is a lot more robust. You need like a CRM, or at least a system in your EMR that you're making sure that you're following up with the people that you're calling on. They need good educational materials. They need access to that doc because they're the liaison between the REI and then the referring providers, where when you're young, you're new, it's you, and you don't need as much of that system. It very often it's just going in. You can go back into the office now in late 2022, and you will often be seen a lot more quickly than a physician liaison will. If you come in and say, I'm the doctor and I just want to come and I just want to introduce myself, I just want to drop off my cell phone number. You can do that as a younger doctor. You can do that with every single OBGYN office in your area. And you don't need to build out all of the materials. You don't need to build the CRM of this is when I followed up with them last, and this is our last point of contact there. You can just go and give people your cell phone number, and you will build relationships by doing that.
Yep. It's very low tech over here. I just had an Excel spreadsheet, and I had the names of the local OBGYNs, and when I would visit them, and then as I got their cell phones, kind of had them down, and you just when you send them a baby, you text them, and they will, now they've got your number, whether or not you gave it to them or not. Now it's in their phone, and they'll text you questions, and that's just you develop that relationship. It does take time.
Here's another little tip for people that are listening. We know that 60% of REI patients are referred by a provider. That means that 40% are not referred by a provider. But guess what? They're all going to an OB afterwards. So that might also practice gynecology, or at the very least, they're in an OBGYN office. And so you reach out to that person after, whether they referred you or not doesn't matter. There's 40% that did not refer to you. And so but you still share a patient. And that's a great reason to be able to connect with those folks.
We definitely do that. Go ahead. Sorry.
Well, you talked about some of integrating things after you establish, and I think the copy and paste model is the way to go when you're starting. I was a guy that started a firm completely from scratch, it's like, wow, I could definitely see the value, having have worked for somebody for 2 years first and then modified that. Uh, not having done that, I can see the value of copy and paste. There's just a lot of shortcuts. And it isn't to say that everything that you're copying is valid for the future, or maybe even the best way of doing things now, but it gives you a framework, because then you're optimizing as opposed to inventing, and you can decide what you want to go on to invent. And you talked about the things that you helped to integrate, or that you started to integrate things after that. What were some of those things?
Just very small variations on stimulation, standardizing how we did postoperative pain meds, and just different optimizing ways that we were drawing labs on certain diagnoses, things like that. I mean, nothing major. I mean, one of the reasons that I decided that joining with John was the right thing to do is because he'd been out for over 15 years. But in our interview, we were talking about papers and research that had come out the month before. So I knew that he was very mindful of the literature and evidence-based medicine, and that's somebody that I could work with. So, I knew that we would continue to challenge each other. And, we don't have journal clubs every other week where we sit down and tear apart FNS, but we do continue to send each other a paper about this or a paper about that, and continue to push ourselves to deliver quality evidence-based medicine in a thoughtful manner. And so, it wasn't anything revolutionary, but I would come to him and say, hey, we're drawing these 2 labs here. I don't find them as instrumental. Let's think about doing it this way. Or, hey, let's change our simulation protocol to shorten this window to this, and then we can try this. And what he taught me was how to implement a change in a clinic without really making everybody upset. And
that's worth exploring. Yeah. How do you implement a change in a clinic without getting everybody upset?
2 patients at a time. So what you do is you have a meeting with your nurses about it. You make sure your head nurse is there, and everybody and all the other staff that implements good clinical workflow is there. And this can be done, after IVF plans on an afternoon, and you say, hey, this research, this literature, these findings are starting to show real promise. And I think that it can benefit our patients in our area this way. And this is what it would look like if I did it. What do you guys see as barriers to us being able to do this? Because inevitably, your IVF nurse will think of something that you're not thinking of, and that's very valuable. And then you say, okay, how do we build this protocol to be maximally efficient, but also be maximally beneficent to the patient? And you kind of you mock up a play patient, and then you say, okay, who's the perfect patient for us to try this on? And I'm not saying that you should just like, hey, I just want to start doing this. Like, I wait for good literature to come out and verify that this is a good thing. And then we say, how do we bring this in the clinic? And then we pick a patient or 2 in one particular month, in one particular cycle, not that we batch, but like in 1 month, and we do it. And if it works, then maybe we do 3 or 4. And then the next month we do half the patients or whatever. And then before you know it, you've got a good number of folks going. And then the last critical thing you do, of course, and any REI is going to know this, is you keep track of those patients and you do the analysis as you go through. You keep a running list of those patients in a HIPAA-protected database that allows you to thoughtfully keep track of those metrics and compare them to traditional metrics. Not only is that the responsible right way to make sure that what you're doing is the best thing for your patients, but that's also a perfect research opportunity for your residents. Perfect example, when I came in, John was there was a paper published in the early 2000s that you could just give 20 milligrams of letrozole on cycle day 3, and that was all you needed to do for ovulation induction instead of 5 mg for 5 days. And so I saw that program. I'd never seen it before. I said, John, what's this? He's like, oh, yeah, it's just something that we saw we do, and it helps with compliance, and patients love it. And I said, well, are the outcomes any different? He's like, I've really not ever had the time to check. I got a resident. She went through, 2,000 cycles of IUIs by chipping through the data, and showed that actually the pregnancy rates are exactly the same. And so the one paper that was published is now 2. So that's just an example of how you can thoughtfully implement change, keep your clinic running efficient, not upset your nurses, and then on the back end, you've got a research project for a resident to get a poster or an abstract or even a paper on.
You're clearing your line of sight by involving your nurses early too, because
Heck, yes, you have to do that before. So if you come in and say, "Hey, we're going to do, drop the end tag, we're doing progesterone," you're gonna get the laser eyes to your soul. So you kind of have to be thoughtful about that, because they see these patients day in and day out. They do what they do very thoughtfully, and they're gonna see the speed bumps you don't see, because they implement those small details in the patient's day-to-day workflow that you don't necessarily have to think about because you're high level. So you absolutely lean on them. I don't see how people don't.
you can apply that to other areas of operational change, other areas of business change with the relevant departments and
Absolutely.
teams there. Here's the benefit that I'm seeing by doing this change that I've seen other places. What barriers do you see here? And then what are the 1 or 2 use cases that you see us being able to apply it here?
And then you slowly build it. Yeah.
You talked about you said read a few good books as you were learning the general field of business. Do you remember some of the books that were most helpful to you?
The first one that John gave me was Good to Great, Jim Collins. And so I wrote Good to Great. I read Good to Great and Built to Last. And then, this day and age, it's there's so many ways to take in information. I do Harvard Business Review and basically all the books that were on my dad's bookshelf. And they're sometimes helpful. They're sometimes not. He was a big fan of traction. And so I read that, and that was okay for what we do. A lot of the stuff that I gather from specific books are a lot of just really just sitting and thinking about things that I hear on your podcast or on other things that are unrelated. So talking to other people about how they do business and what they do is more of a helpful thought exercise than necessarily anything about business. The reading the business books is most helpful, and learning the language. It's kind of like, reading a book in Spanish to learn Spanish. I'm not necessarily absorbing the content of the book, but I'm learning new words in Spanish, if that makes sense.
Well, learning a new language is a good way of thinking about it too, because don't beat yourself up when you sound like a baby at first.
I don't know what that means. What are you talking about? Wait, does it just mean this? Why don't you just say this? Well, that's not what we call it.
Yeah.
Okay, fine.
Yeah, and it can be one of those things where it's like, in adolescence, or sometimes even in adulthood, there'll be a word and it's like, I've been using that word incorrectly for how many years?
Well, that's the English language for you. It's okay. There's a lot that's forgiven.
And that's true for business too. I would be interested in getting your opinion on traction a little bit, which you said is okay for what you all do. And you're talking about Traction by Gino Wickman. That
I don't remember the name of the author, embarrassingly, and it's been probably 5 years since I read that, because I read it coming out of fellowship. But the biggest takeaway for me was just understand what seats you need as far as drivers, and then make sure that the right person has the right values that are filling that seat to make sure that they're doing what they need to be doing. And that was the takeaway for me. And so I do think about that a lot, but the rest of the book was just kind of washed over me, if you will. But I remember, because I think about that now, as I'm doing end of the year evals with my staff, I'm thinking, okay, here's all the things that you embody as a value, and these are what's important to you, and this is how this benefits who you are in this seat. And so, and I feel like we've got a good team in that capacity.
So I've wondered about this a lot. So the book that we're referencing is called Traction by Gino Wickman. It's about EOS, which is the Entrepreneurial Operating System. It is an operating system for businesses, typically of 10 to 200 people. And I have used it a lot for giving some counsel to REI practices, but I know that there's a limitation, and it has been extremely fundamental for my firm. So the book posits, and the operating system posits, really 2 or 3 cardinal arguments, one of which is that it takes 2 people to run a business. It takes the visionary, the person that is responsible for the future value of the organization, and an integrator, the person that is responsible for actually executing the day-to-day operation. So as those translate to contemporary business titles, you might think CEO, COO, but that structure isn't totally possible in the same way in a medical practice, because you have very often when you have a CEO as a business person, they're not the physician, so they can't be the sole owner, at least of a practice group, and if they are of a network, then the organization structure is different. So I see that as a potential seat limitation, but I do think it is. I think it's really useful for looking at the accountability chart of EOS, which you can email me for. It's on the Fertility Bridge website in a lot of places, and I've said that I want to make one for REI practices, and I still haven't yet. Maybe
you're not far. I've seen you try.
So but I think it's useful to look at, because you can see yourself as an REI in multiple seats. You can see in one of the seats that you're going to be in is you're going to be under the visionary and integrator seats. You're going to be even under the three main seats of operations, sales and marketing, finance and compliance. You're going to be under one of the operations seats as a producer. And so you can be in multiple seats. You can be in that operations seat when you're thinking of yourself as the medical director, as the practice director. And if you're the senior partner, in a different one as the visionary, and possibly also the integrator. So I think it's useful, even if it doesn't translate 100%, to be able to see, okay, I'm in a lot of different seats here. Which ones can I get out of?
Or it's just the wrong model. So don't think of it in that simplistic of a term as just having seats. Maybe the RE is a giant circle around the whole model, and the practice itself is each of the people that you employ in each of those seats, and then draw a big circle around the whole thing and just write REI, because we're over and around and integrated through each of the seats.
Which makes trying to map it a nightmare.
No, it's just one more circle. Just draw a circle around the whole thing. There you go. You're done.
But the point of the seats is to be able to delineate. The whole point of a seat is to be able to say, this person is accountable for this. And the reason why EOS is so successful is because you can have one person in more than one seat, because a lot of organizations are small, but no seat is occupied by more than one person. It's what allows you to say, this is who's finally accountable for this domain. And because the REI is instrumental, irreplaceable throughout the circle, it is harder to solely assign accountability to different folks in different seats.
Unless the RE delineates what tasks you are responsible for in each of the seats very, 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 very precisely and very, very clearly. Yeah, I agree.
Another book, when you were talking about the profit and loss thing, I think of a recommendation that was given to me by Dr. Sable. It's just called How to Read a Financial Report. It's as interesting as it sounds, but it's fundamental. And if you have an MBA, you don't need to read this book, probably, but but again, sometimes it doesn't hurt to go back to fundamentals, and you may have missed something. But if you are really getting into the financial reports, and profit and loss, which is the income statement being one of them, cash flow report being another, balance sheet being another, then it's a good book to read. Do you remember any lessons that really stood out to you as you were learning the income statement?
No, to be honest, it's not so much a specific lesson. It's just making sure that you understand how your items are lined out and how each of the buckets are filled and how you are responsible for each of the different revenue drivers. And that's going to be individual to each practice, which, I mean, it bears repeating that this conversation is not. These are overarching things to generally think about. It's going to be different for an academic model. It's going to be different for an employee model. It's going to be different for a private practice and a hybrid model. All these things are are very different. So a Shady Grove and an RMA and a University of Alabama and Fertility Answers in Baton Rouge are all four very different conversations. And for even me, it's even more complicated than a private practice in Baton Rouge because we're affiliated with Ovation. So that's that further complicates my model. But that was an active decision that we made together about that. And there's certainly pros and cons to that relationship too. And in my opinion, more pros than cons.
We could talk about those pros and cons. I did an episode with that a couple years ago with Dr. Storment, and we can link to that episode for people to go back to. Today, we talked about the expectations of incoming docs around geography, research, surgery, and onco fertility, the 3 goals that they have in their first job, which is pass the boards, learn the business, pay off debt. And I think that's a useful way of thinking about that, Neil, that maybe I need to adopt a little bit more because I am very diligent in telling people how they should remove the mutual mystification in their negotiations, try to button down what's going to work out for them. But what you're describing is it might be okay if it doesn't work out because you in that first job, because you have 3 goals. And one of them is to learn the business. And so if you pass your boards, if you learn the business and you pay off some debt significantly, 2 years and 3 years into working for a group, and then you end up going on to somebody else, it's probably a pretty okay thing.
You don't go to jail. You don't go to jail. I mean, it's just your life will have another move, but good Lord, you've been moving every 3 to 4 years anyway. So don't go into a job thinking that you want to move in 2 to 3 years, but go into a job that you have a reasonable chance at loving in a place that you probably won't hate. And I feel like with microgeography, you probably won't hate where you live, no matter where you live. Because you can find happiness just about anywhere here in America, which is a wonderful place. And then if it doesn't work out, then Lord knows there's another job available somewhere down the road, and that is okay. Granted, there's the non-competes and the people that have to be in this area. That's a different conversation. That's different for them. If I have to live in Atlanta and I have to sign a non-compete, they have a different sort of stressors on them. But that situation, I think, is not as common as the folks that can be a little bit more flexible with their geography.
We talked about learning the general field of business, the financial reports, the operational workflow, learning how you even write in the EMR, a easy stepwise process for implementing some changes that you learned, and then even a bit about the operational structure. We probably also could have explored your criteria for partnership because you're now a partner with Dr. Storment at Fertility Answers. We can save that for another episode. You can include that in your concluding thoughts if you'd like, but how would you like to conclude, Neil?
Yeah, no, I think you did a great job, and you've done a great job in talking about different practice models and how people buy in. I don't know that I can contribute anything to that. I'm happy with my practice partnership. Took some lessons from some stuff that you talked about, and took some lessons from some stuff that my dad taught me and that I just learned on the fly. And to your point, talking to John, mutual demystification. We said what we did and didn't want, and it worked out well. And I've been happy being an affiliate with Ovation. I've been able to buy into the parent company, and that to me is like a great way to leverage risk. If my numbers are lower in one quarter because less people are doing IVF in that month, I'm still doing well by being invested in the other IVF centers around the country. I get to do research with the Ovation network, and we get really access to top quality embryology staff and some beautiful embryos. So I've been happy with my partnership on both fronts there. But like you said, you've done podcasts on all of that, so I don't want to belabor those points. I would say that the one other thing that I would say to the graduating fellows is it does take a few years to build. What you want does not happen on day one. Even if you do want that day and a half to sit and do research, that shouldn't happen on day one. The day and a half for research when you come out needs to be shaking hands, meeting people, learning the clinic workflow, learning the business. becoming a contributing member to the partnership. So a lot of folks say, "Oh, I want look at their lifestyle, look at what they're doing, look at how your partners live, and see if that's how you want to do things." That's only kind of true because the folks that work there have been working there for years. I'm in my 5th year now, and so now I'm able to bring my kids to school, come to work, see patients, do surgery, do IVF, and then leave at a reasonable hour because I've spent the last 4 years developing a good clinical workflow with my nurses and having a good understanding with my administrative staff and bringing on a really good mid-level to help me integrate patients when I'm not here. And so now I have a really balanced life. My first 4 years were not balanced. I worked harder in those 4 years than I did in a lot of residency because it takes time to build. So you can have the life you want, visualize the life that you want, think about what's important to you and what you want to contribute to the place, but understand your contribution is going to be equal to your say at the table, and understand those differences in values are real and they have to be respected and just compromised on. And then you got to put in the work to build the infrastructure to have what you want. And that's okay. But just understand that that's going to come. It takes a few extra years of hard work, but it's totally worth it because this is the best job on earth.
I think your advice about paying off debt parallels that it takes time, meaning so many physicians, after going through 15 years of higher education and training, where you either totally racked up debt in undergrad and medical school or then made not much more money than a junior marketing person for residency and fellowship. And now it's okay. You're finally starting to realize some income potential, and maybe you want that car, you want that big house, but there is something to be said for taking that time to pay off the debt, and then the cars and the house and the big vacations and the other nice to haves can come a little bit later.
Yeah. And time, you be thoughtful about how you're building things. And if you will, in a short amount of time, it'll pay off, and it flies by, but it doesn't happen. It doesn't happen right when you start your clinic. You have to put in the work to build the patient load, to build the rapport with the referring docs, and to understand your market. And then from there, be intentional, understand what you're bringing to the table, and then have a great life.
You mentioned earlier in the show that now that you're 4 or 5 years out of fellowship, that you hear less from people because your peers aren't in fellowship anymore. I hope that this episode plugs you back in, and you representing the sophomore class, those that have bought into partnership within the last year to 2, that have been out of fellowship about 5 years, that have been underrepresented on Inside Reproductive Health. You're a really good person for those folks to reach out to, and I can speak to your character, and I hope that they do. So if people want to reach out to Dr. Chappell, please feel if you want to email me, I'll happily make the connection.
Sure.
And I hope they do, Neil. They would be wise to talk to you.
My cell phone is out there with most people, so if anybody can feel free to text or call me too. I don't care. We're good.
Neil Chappell, thank you so much for coming on Inside Reproductive Health.
Thanks for all you do, Griffin.
You've been listening to the Inside Reproductive Health podcast with Griffin Jones. If you're ready to take action to make sure that your practice thrives beyond the revolutionary changes that are happening in our field and in society, visit fertilitybridge.com to begin the first piece of the fertility marketing system, the goal and competitive diagnostic. Thank you for listening to Inside Reproductive Health.